Good afternoon, and welcome to Southcentral Foundation's Nuka Fireside Chat. Thank you so much for joining us. My name is Gil Prickett, and I'm the Senior Clinical Advisor for Learning and Development at Southcentral Foundation. I'll be your moderator this afternoon. In response to COVID-19, healthcare is rapidly changing, including here at SCF. In these chats, subject matter experts from Southcentral Foundation will share some lessons learned and then open it up to you for questions and comments. At the bottom of your screen, you'll see a Q&A button. Here, you'll be able to submit questions or anything else you may want to share, and I'll make sure to direct your questions to the presenters. After today's chat, we'll be sending you a quick survey. So please give us your feedback so we can improve the next chat. If you're having any technical difficulty, please email us at scfnukaevent@scf.cc, and we'll have someone reach out to you to help as we're able. That email again is scfnukaevent, all one word, @scf.cc. Now, I'd like to introduce our panel for today's fireside chat. Dr. Michael Cooper is a board-certified family medicine provider who has been with SCF as a primary care provider since 2016. He received his MD from Michigan State University College of Human Medicine, followed by family medicine training in Duluth, Minnesota. Upon completion of family medicine residency in 2006, he completed a 2-year Epidemic Intelligence Service Fellowship with the Centers for Disease Control and Prevention in 2008. Dr. Daniel Hartman serves as SCF's medical director. He supports providers in offering the relationship-based care that has made SCF one of the world's leading examples of healthcare redesign. Dr. Hartman is a board-certified family medicine doctor who attended medical school at Temple University in Philadelphia. He completed his specialty training at the University of California, San Francisco, and has been a family medicine doctor since 1999. Michelle Aregood serves as SCF's Director of Quality Assurance. She has been at SCF for more than 13 years. Her team ensures the execution of activities that facilitate SCF's quality management program and making sure that it complies with local, state, and federal regulations related to accreditation, risk management, safety and security, employee health, infection control, and legal requests. And now, I turn this over to our panelists for the afternoon.
Thank you, Gil. Thank you all for joining us today for this fireside chat. We're excited to be able to share some of the lessons that we've learned and the things we're doing at SCF in response to the COVID-19 pandemic. I want to start a little bit with just about who we are at SCF. SCF is part of a vertically integrated tribal health system based in Anchorage, Alaska. Right now in Alaska, we're enjoying some really long daylight days here in Alaska. We're about ready to see summer solstice this weekend, which will be our longest day of the year. I think we're all looking forward to that. One thing that happens in Alaska during the summertime is you sort of forget that it's getting later. Last night I was out in my yard at 11:30 at night gardening and forgetting that, I have to get up and go to work the next day. So the days are really long. It's beautiful outside and we're enjoying a little bit of that here in Alaska. So at SCF, we support about 65,000 individuals through our healthcare services. And in partnership with the Alaska Native Medical Center, we serve about 200,000 individuals through the Alaska Native Medical Center. We employ at SCF over 2,500 employees, and we provide services such as primary care, pediatrics, optometry, dental, addiction services, we have residential services, and we provide these services in a variety of geographic locations, not just in Anchorage. So some of the locations that we provide services are in remote locations that we can only travel to by boat or small plane. So it makes some of what we do a little bit more challenging, but we've gotten really good at it over the past 15 or 20 years. As the pandemic came to, we're a little bit isolated in Alaska, as you might know, and so we're a little bit fortunate in that we haven't been hit really hard with COVID-19. We've been able to socially distance and isolate quite a bit. And early on, our governor issued what he is calling a hunker down order or a social distancing order, where we all had to stay at home to help flatten the curve, which we successfully did quite a bit in Alaska, and we're grateful for that. But at SCF, the way that we began looking at the pandemic in late February, early March, we sort of broke it up into 5 different buckets of how we wanted to look at this. And one was leadership, and what we thought is we wanted our leadership to be fully present. We wanted to be available and visible and transparent. And we wanted to be able to make decisions quickly. So in the beginning, our leadership was meeting daily. And so instead of setting up a traditional incident command, as you might do in an emergency preparedness or emergency situation such as an earthquake, we set up an altered incident command, which was led by our president, CEO, and vice president leadership team. The goal of that in the leadership bucket, that in the slide that you just saw, was that we wanted to be able to make decisions quickly and systematically across the organization. And that is, and we're still doing that. We're not meeting daily, we're meeting 3 times a week now, but that is still happening because the pandemic is still occurring. Also, our leadership wanted to be able to model self-care and compassion as we move through this pandemic. The next thing that we looked at is clinical operations and care delivery. We were fortunate in this regard because our systems and processes that we already have in place through many, many years of building Southcentral Foundation allowed us to do this somewhat seamlessly. Our organization is a relationship-based organization, and we're based, everything that we do is based on the voice of the customer owner in partnership with integrated care teams. And so that allowed us very quickly to be able to shift the way that we were doing things to a model that we needed to move to for this pandemic. A lot of telehealth and remote work was able to be shifted to quickly, and we'll talk more about that as we chat further. The next bucket that we looked at was business operations. We were able to shift the workforce to moving remotely in lots of areas. What we decided is that what was the critical infrastructure that needed to be on site and what support services could work remotely. We worked closely with our IT department to make sure that we could support that. And so still currently in our response plan, many people are still working remotely as we move through this. The next thing that we looked at is our workforce to adjust schedules, to communicate continuously, and to reduce any paperwork. We wanted to make sure that we had enough supplies and we had enough supports for our staff during this pandemic. And so we implemented a lot of temporary procedures and processes that could support our staff across the organization. Things such as temporary housing if they needed housing during the pandemic and they were coming into our clinics to work in more high-risk areas, or a scrubs process, things like that we implemented. So those are sort of the broad, high-level buckets that we started looking at in the early phases of this pandemic and that we're still utilizing as we are in the middle of this pandemic. Michael, I'm going to turn it over to you.
Oh, great. Yeah, thanks so much. And thanks for the opportunity to kind of give the perspective of the provider on the ground as well. Like Michelle said, into February and early March, all of this planning was going on. And I think sometime around early March, when Alaska had its first few cases, small clusters spread in the state of Washington, I think the decision was made to set up sort of a pop-up respiratory clinic. And there's opportunity later to talk a little bit about a train-the-trainer model also that was discussed and being implemented. And part of the reason to go over to that pop-up respiratory clinic is also to build in more surge capacity. The initial phase here was really looking at the potential for a big overwhelming surge and what do we need to do to prepare for that and to streamline care for customers that present with COVID symptoms. So I'll talk about that in a little bit more detail in just a second. There were a lot of other things going on rapidly at this time as well, a door screening process, which again, we can talk about more if people have an interest a little bit later in the question and answer section. Employee health changes as well, to develop a program for screening employees for COVID, dealing with employees that might have been exposed or even positive with COVID. And, as I kind of reflect back on this initial stage, this is an ongoing pandemic for who knows how long, but when we look back at this initial emergency response stage, and I think about all of the decision-making, the processes that were involved in making all of this happen, the task force creation, what they used to make decisions day to day, the principles they were operating on, all of the openness and the trust throughout leadership that was being used. It made me think, as I was thinking about this presentation, about how I'm relatively new to Southcentral Foundation and to the Nuka model. And it seems like almost yesterday when I was going through new employee orientation, and you've got everything new as a new provider taking on a panel and all the clinical responsibilities, and then also suddenly being exposed to this incredible model. And at first it's like, oh my gosh, what have I gotten myself into? In a good way, though. The past 3 years up until the onset of this pandemic and the response, it was a slow realization of a lot of the strengths that are included in this SCF and in this Nuka model. The shared responsibility, the open exposure to leadership, the transparency, the trust that develops, the customers being at the center of this integrated care team, and the provider not being the center of a diagnose and treat model, but this customer and their wellness being at the heart of it, and the provider just being a part of that, an important part, but a part of that. And then this great integration through every level of SCF services that are offered it was really a nice, slow appreciation over the course of 3 years. And then suddenly when COVID pops up and this emergency response happens, and I was a volunteer to be the medical lead for this pop-up respiratory clinic, it gave me a chance to very quickly see how important a lot of these system processes really are. And probably one of the more important ones is this sense of team and shared goals and shared purposes and almost a sense of family. Because when you're putting people into a situation that disrupts their normal processes and you're putting them into a situation with new teams rapidly developed, and then on top of that, you layer on the unknowns of this pandemic sweeping the globe, it's just a perfect setup for a lot of anxiety and a lot of frustration. But it worked out really well, and I think a lot of that had to do with the basics of the SCF system in Nuka. And on the next slide, the actual creation of the respiratory clinic wasn't too complicated. It was a ton of work, but it was pretty much setting up and making sure you've got your space, your staff, your stuff, and then developing the appropriate systems. So looking at the upper left first, the space wasn't too difficult. We had a disruption in services, a lot of things going more virtual, and so we had a lot of empty space. So we identified a first floor clinic, the clinic, my home clinic, because it was easy to access from a parking lot that had easy entrance and egress, that we could sort of isolate to just people coming in that needed to be seen with COVID symptoms. We had the ability to expand. In fact, we expanded initially from that first clinic down the hallway to another clinic. We had access to radiology, which was pretty easy. And so we had the ability, and we were planning for a potential surge. So we had those plans worked out where we would expand. And to isolate the other parts of the building as well from this COVID respiratory clinic. The staff part, right up front, a manager was identified, Heather Scaife, who really did most of the work here in creating this clinic. And, we were sitting together early on, and one of my concerns was, how are we going to get enough people to staff this? We wanted at least 4 primary providers. The pediatrics clinic already had a kind of respiratory hallway going. They were going to join us. We were talking about how are we going to get enough appropriate staff to staff this? Will we get enough volunteers? And it was just amazing. And I think it goes back to this, again, this whole sense of a true team and family and togetherness and shared purpose. We were able to staff every position and then even get a bit of a ready roster just with people who were stepping up and willing to, when you ask them, hey, would you like to join a clinic where this unknown global pandemic is going and we're going to be seeing these people that present with these symptoms, how would you like to volunteer? And we actually got enough people in all of these disciplines. We got enough providers. We even had providers who had busy panels that were still busy with their panels virtually that wanted to come and volunteer there. So we were saying, well, why don't we have enough? Why don't you'll be on the ready roster and you can, spend some time there, but you've got other responsibilities. We had providers who really shouldn't have gone into that environment due to age or comorbidities who were asking, hey, I want to be on that roster. How do I get in there? We're like, just stand by where you might be used. You just be ready. And so we had some people that were on the ready roster that weren't initially volunteers up front, but they were willing to if needed. So plenty of low-level anxiety on the part of everybody in the world, I think, as this continues to unfold, but especially when we were anticipating a possible surge, as you might expect. And then as we looked at, the stuff, we had, I think, a great advantage of access to lots of testing right from the get-go, which helped us a lot. We had enough reagents. We had, with the lab across the street, we had access to both a walk-up testing site or any test that we needed to get run. We were able to test them right away. We didn't have to, initially, if you remember, there were criteria. Well, if they meet these criteria, if they're a healthcare worker, consider testing, don't test other people. We didn't have those restrictions. So we had those recommendations that would come through from whether it's the state of Alaska or CDC or the World Health, but then we also had a box that said provider discretion. So if you just wanted to test somebody that didn't quite fit, you were able to, and we had the access to it, which really, I think, was a real game changer for us in identifying some of the cases that we did really early and being able to get them contact traced and not spread. And then regarding stuff and PPE, we were aware and keeping track of the global and the national shortages and the potential for shortages if a surge were to affect us, but we didn't have that acute shortage right up front. So we were putting in place processes in the clinic to preserve PPE. We were doing things like, as a person would present that needed to be seen in person in this clinic, we would have them roomed immediately, no close contact with them, and then the provider would be the one that would, over the phone or from the door, get a history, determine the need for PPE, and then they would go in PPE if indicated, and they would get vital signs, they would do an exam, they would get any specimens that were required, whether that was a swab for COVID, a blood sample, whatever it was. And so the goal was, and it ended up working most times, was that one set of PPE was used for an entire encounter. And then as you talk about systems, I mean, that's the more complicated thing, trying to get all of your plans in place, trying to take what people have been doing and changing it either slightly or in a large way and putting new people together and doing something that usually takes months or longer to do, but doing it very, very quickly. And like I said initially, I think that the reason this worked so well, this initial stage of the response, was that it was built on this great foundation. And I'll let Dan speak a little bit more about that.
Thanks, Mike. So yes, we did at SCF have a tremendous foundation to carry out this response and to continue to carry it out. There's a long-standing comfort with communication with leadership by staff at pretty much every level, and that was super helpful. I could see it. I think everybody could feel it. There's a culture of trust at SCF that we didn't have to battle with trust at all. It was very comforting, actually. And our long-standing reliance on shared principles in our leadership decision-making and our iterative change and planning processes, we rely mostly on shared principles. We're not an organization that sticks with policies and procedures in a sort of a sticky way, I'll say. Moreover, we really look towards conversation with each other, with our customers, with our community, And when there's questions, we fall back on shared principles. So that allowed us to really rely on PDSA and a rapid iterative change cycle that was super helpful for us in most every way. We had along with all the changes that Mike mentioned here, a sort of relentless focus on what we were doing for the people that we cared for. The continuity in our relationship was with our customer owners and with our families was a really comforting focus for us, I think. And there was a shared comfort when we had customer owners speak with us, visit with us over the phone, virtually or otherwise. It really sort of lifted us, I think, in a lot of different ways. And I felt myself like we were relying on our long-established relationships more than ever, just as everyone in the community was relying on long-established relationships and family connection. We have a real focus by Baldrige on workforce development and workforce wellness, and we were able to pay attention to that, thankfully, during this response, and we're continuing to pay attention to it. Things like focusing our BHC efforts on wellness and help for the staff around them, daycare options, assuring alternate pay schedules, being very transparent about those pay schedules, housing options like Michelle mentioned. So in a lot of ways, if we had successes in this response, and if we have successes going forward, they're going to be successes that we've had all along for 20 years, specifically continuity in relationships. We rely on that. Our ability to test change, our ability to move through a planning cycle quickly, easily, and test it. All of that led to us to really move easily towards a platform that was more virtual. And we have long experience with virtual visits. Up to 70% of our encounters are virtual without COVID. We have RN case managers that can generate visits, essentially, that we sign off on as providers 15 to 20 times a day. And that frees up quite a lot of space for us for in-person visits, maybe 10 or 12 in-person visits a day. That model allowed us to easily spool towards more telemedicine, more virtual visits, while relying on our planning cascade, while relying on continuity and relationships. Our relationships and trust with our villages was something we were also able to rely on. Historically, we partner in every way with our village councils in design and operations. And we were, this response has been no different. We've been able to listen and act together, and in some really complex decision-making around transportation in particular. Alaska is like many areas of the world where maybe you can only fly to a village, and that in a COVID response is tougher, of course. We've relied on a culture of doing today's work today. Our response time has traditionally been very fast, very quick. The COVID response was no different. And it seemed like we really stepped on the accelerator, and we were able to do, I think we were talking earlier this morning about how we were doing things that would usually take us 12 weeks in a planning cycle. We were doing them in 12 hours. So our response time was fast, and that was helpful. So we have some successes, I suppose, that really are foundational to our Nuka system and our integrated care model. And the transition to telehealth, which I think if some of you have seen the prior Fireside chats, there was a real detailed conversation of our transition to telehealth. We can talk a little more about that if there are questions. But that transition didn't come from nowhere. It came from our integrated care model. It came from our Nuka system of communication and openness and trust. And very importantly, it came from our Baldrige model with 4 ovals and our planning cascade and rounding and just everything that we've done forever, which is sort of in our DNA. We a couple quick points on our employee health and our testing capability. We had quite highly developed and I think sophisticated employee health if-then protocols developed in a matter of, I think, 10 or 12 days or so. And that led to a lot of trust by staff that we were focused on staff safety and wellness. We, as Michelle mentioned earlier, made an important strategic decision to have our senior leaders essentially run this response, and they continue to run the response so that we can pay attention to whole system design. We never really had an incident command that was rolled out and then spooled down. It continues to be our senior leaders that are running this response. And then another organizational win for us, I think, is transparency. We've been able to communicate on a day-to-day basis where we are with our testing capacity, where we are with positive, negative pending results, where we are with staffing, where we are with our planning. And I think I'll hand this off to Michelle.
Yeah, I just want to add to what Dan has said a little bit about some of the things that we've learned through this. I think that our relationship structure, we have a set of core concepts here at SCF that there's a training that we all go through to learn a common language and to learn really about ourselves and how to interact with one another. It's an initiative that is our President CEO initiative. And it's a training, a 3-day training that we all go through. It's required, and it allows us to have a common language and know a little bit about ourselves and a little bit about each other. And that foundation really, I think, supports our being able to do a lot of the telework and remote telecommuting that we were able to do very quickly. We're already in relationship with one another, not just our customer owners, but also just with one another. So it's very easy to be able to know who to go to and who to interact with and who to work with in different scenarios. Many of us have been here many, many years at SCF. We had a lot of longevity here. So we're fortunate in that regard. Also, I think that some of our data mall, we have a data mall where we house lots of different things, and without that, probably we wouldn't know a lot of things that we know about some of the stuff we're doing through this pandemic. So we're grateful to be able to have that platform as well. And then our leadership structure, we have a very strong leadership structure with our 4 ovals, as Dan and Mike, I think, both mentioned. And then we have senior directors who've been put in place by our president and CEO. And they form our operations committee, so we definitely use them to disseminate and to get information and disseminate information throughout the workforce. And then we have an executive leadership program that is put in place by our president and CEO as well. And so all of those structures really support everything that we're doing, and being able to do, as Dan said, what we would normally do in a longer period of time, in a very short period of time, we're able to turn things around very quickly because of those relationships and structures we already have in place. The slide that we're going to put up now just demonstrates, we talked about transparency and making sure that we are giving our employees information all the time. In the beginning of this pandemic, we made a decision that we needed to feed information proactively to our employees all the time. And so every single day since the end of February, we produce something we call the daily update, and it goes out to all employees. And this is just a sample of the beginning of the daily update. We give a lot of data, internal data, on what are the case counts and numbers internally, how many are we processing, those sorts of things. But we also give information about the global data, what's going on with COVID globally, and what are the local numbers as well in the state of Alaska. And we talk about bed capacity, ventilator capacity, those sorts of things. And we also publish any new procedures that we may have put in place, temporary procedures related to COVID, or testing sites, or how encouraging employees to be tested. We publish a lot of things about how to prepare at home, how to prepare in the community, how to take care of your aunties and your uncles. That sort of information is very important to us to support our workforce in that way and make sure that we're telling them everything that we know. Would you like to add anything to that, Michael?
The only thing I would add would be when you mentioned the core concepts course, and I remember that well, a few years ago, and all of the workforce training and the motivational interviewing and the team dynamics and the individual 5 dynamics programs that all employees go through. That was something else that when you put people into this new respiratory clinic with people they may have never seen, or ever worked with for years, you've got that common culture, you've got that common language, you've got that shared belief system and shared responsibility already. So it just made it that much easier. I mean, everything else that you mentioned, but just thinking again back from my experience right down there in the respiratory clinic, it just made that, I think, flow right from day one that much easier. And problem solving, it made it that much easier as well.
So the next slide that we're going to put up is some data graph that I think Dan's going to talk about a little bit about some of our in-person visits versus what we saw when we started doing some more virtual visits.
As we talked about earlier, the tradition at SCF is to do quite a lot of work virtually. We, in our day-to-day, we're working as well, it's a dyad, the primary care provider and the case manager, and then we have CMAs and CMSs. These are case management support staff and our medical assistants that are really involved in the day-to-day of the flow and finding out what we need to do for somebody to improve outcomes and to improve wellness for that person. But a lot of that's virtual. A lot of that is proposed to us in computers in our day-to-day. When we looked to transition more to telephone and video visits, we had to, absolutely. And this graph is an interesting one to look at. On the left, the day-to-day visits in blue, I believe, are trending in the range of about 540 a day. This is outpatient visits. This is not ER or fast track or specialty. The experience that we had was probably very similar to the experience that many of you viewing this experienced, which is that everybody ghosted the clinic. Everybody ghosted the ER. They tried to stay away if they could, and for the right reasons. When we responded to that demand, we had a lull. We had a lull of a couple of days, and we realized, oh my gosh, we can call everybody. So we started calling our elders first, and we started calling everybody, essentially. And we moved into telephonic visits first and built in a rapid planning cycle of video, an embedded video visit. And we were able to essentially cross over numbers where we were not absolutely replacing in-person visits with video visits and telephone visits, but we were replacing maybe half of them. And then we were continuing to do in-person visits, both respiratory, non-respiratory, OBGYN, pediatrics, behavioral health, to a more limited degree. And our total number of visits pushed over, I think, 400 a day on average. So in a quick, within a week, within 5 days or so, you see that crossover. So I think that's a really interesting graph. And this is on the right, actually, if you could go back to the graph there for a second. On the right, you can see that our in-person visits have begun to climb again. That downturn at the very end of the graph is essentially a weekend, but the in-person visits are beginning to climb again as people are more comfortable coming back, and as a consequence, our telemedicine visits are declining because the same teams have to do essentially one or the other. And we have a sort of hybrid approach right now where maybe 2 or 3 visits in our day are telehealth visits, even when we're in the clinic.
Yeah, and if we want to move on, I could start with some lessons learned. Yeah, so, from the respiratory clinic perspective, I think I reached out to our manager, Heather, and Ellie, the medical assistant supervisor, to get their input too, and we chatted about this. Just again, looking back at this initial emergency response in the context of this, ongoing pandemic that we're all dealing with. And one of the first things that came up was just the immense amount of work. And everyone knew it would be a lot of work, doing something different, creating something new, even though everything was pretty familiar. But it was more than I think anyone anticipated. And I think earlier this morning, Michelle had mentioned remembering these 15+ hour days. And Heather and I had discussed we don't remember most of the early part of April. It's just all one big blur. And just constant meetings, communication via email, via voicemail. And, there was this second floor, like a war room that was set up that was just constantly occupied. And just during the day, you would just get a text or a call or a request to come up to address some other issue or some change, and things changing every single day, and all with this on the context of an unknown, not knowing what's going to happen. Is there going to be a surge next week? And what do the models say? And can you trust the models? So just a lot of work constantly, and ongoing work, of course, in all realms. But the constant communication, the constant check-ins were critical. And we have a nice philosophy of check-ins here. And so whenever anybody has a question for a supervisor or anyone else, big or small, they might just say, hey, can we check in? And sure, let's go to a room and let's chat about it. And it's like getting stuff out into the open. It's like Dan had mentioned, not leaving anything, addressing everything right away, and that includes issues that come up. It's encouraged just to say, can I have a check-in? Let's get this out in the open and deal with it now. But there are a lot of them, especially in the context of creating something new in the face of a pandemic. So just planning for it, embracing it, not starting to get resentful about the constant interruptions of, hey, can we have a check-in? Hey, I have a concern. Hey, I have a question. Just anticipate it, embrace it, and know that it's better to address those things now than it is to put them off or not have them addressed. Anticipating difficulties with change, desire for definitive guidance. I think that a lot of people operate with a comfort level of having protocols or having definitive guidance, knowing what they're supposed to do in certain situations. So sometimes when you're confronted with a new respiratory clinic with a new pandemic and there's not clear guidance, and you're making it up as you go along and you're changing it, frequently, it can be hard sometimes. So having empathy for that, having empathy for the anxiety surrounding this unknown was important. And I witnessed this all the time in that clinic. And part of that embracing of the unknown, embracing of fears, being open about not knowing, being open about and clearly communicating what you do know was important, but also being comfortable voicing and sharing what you don't know, and voicing and sharing your uncertainties about things. And that's not a bad thing. Exude your competence, exude your confidence for the things that you're confident about, but don't be afraid to share what's unknown, because that's what a lot of people are thinking. And in the end, I think they appreciated that a lot more than being confident about something that you're on shaky ground or that might end up changing. And then, we had challenges, very few, but challenges with integrating, sometimes some staff that weren't excited to be in that setting, but had to be in that setting, and just dealing with those again with the things we talked about earlier, just catching things out up front, having the check-ins, addressing things as they come up, and kind of having that time set aside and anticipating that those things are going to come up. And then maybe the most important point that was brought up as we discussed lessons learned from the respiratory clinic was that there are no little changes. Like, one little change has the potential, and it will snowball if it goes unaddressed. So sometimes you can make changes to protocols and algorithms or to workflows and just sort of hope or assume that they made it all the way out to everybody that needed to know, and using your established protocols for making sure everyone's aware of those changes. But when the consequences of people not getting that information or not following those changes are increased potentially, like they are during the course of a pandemic, you really have to find out ways to address and make sure everybody, all that information is getting disseminated broadly and everybody is up to speed, and that any questions about those are addressed. And I don't know if Dan or Michelle have any other thoughts about more broadly lessons learned also.
I'll say that for me right now, I'm still learning through. I mean, we're in the middle of this still, and Alaska's seen some increased case counts, more than we've seen in the beginning, actually. And so we're still in the middle of it, and we're still learning. And one thing I'm noticing is that I work in an organization full of innovators. And I knew that before, but I'm noticing it a lot more now. And I'm noticing also that I have a leadership team that not only allows this innovation, but just really values it. And so I'm noticing that a lot now. And I think that some of the innovation that I've seen through this, things like thinking outside the box. Our health education department has a store that they typically have our customers come to purchase maybe some supplements or different health food items. And instead of doing that, they're doing what you might find at Target or Fred Meyer. They're having curbside pickup. Or in medical services, Dan and Michael, their group has innovated as far as not just seeing customer owners with respiratory symptoms outside of the clinic, but they set up a tent outside for those customer owners who maybe don't feel comfortable going into the clinic to do routine things like immunizations or other lab draws outside. Just a lot of innovation is occurring, and so I'm noticing that and appreciating it. I'm also, I've learned what kind of face mask I like, so I've learned that. This is a lesson through this whole thing. I like the more flimsy ones, I think, that have a pocket that you can stick things, you know, a tissue or some other filter in, so I've learned that. I've learned that I have to have many of them so that I can wash them frequently. Yeah, and I think that I've learned that we're learning still here at SCF, it's not over. We're learning that we have to pay close attention every day, and we can't let our guard down, and we're doing that, and I'm grateful for that.
Well, for me, there's really one overriding lesson. It's that it's the capacity of humans to adapt. And I think I mentioned this morning, I didn't really feel in my wildest dreams that this kind of the degree of change that we've carried out could be carried out. And I think most of you who are listening have probably carried out similar change and are pretty astounded yourselves. And to me, it's really just a comment on the capacity of humans to work, innovate, and come together. Another lesson might be, as an add-on to that, is the importance of empathy in working in teams and groups. That if we're giving each other space and meeting each other where we are, we tend to achieve more. So, Gil, I think that's what we got. Maybe can open up for questions.
Great, thank you guys. So I've got several questions here, and I'll start with this one. There was a request to maybe talk more about kind of the virtual model, virtual care model, maybe in terms of time given back to the provider, in terms of availability, what kinds of things maybe we're seeing both pre and post COVID response by allied health providers. And how has all of this been received by not only customer owners, but also staff?
So I'll speak a little bit to the non-medical services piece of it. We're doing a lot of things outside of medical services as well, virtual behavioral health, virtual learning circles, and those things have been received exceptionally well. We're getting a lot of good feedback from both customer owners and from employees, and our no-show rate, I think, has decreased for some of the telehealth since we've gone virtual for some of those appointments as well. So lots of different things outside of just medicine as well. Lots of support services with regard to, we have learning circles for employees and for customer owners, and those are all happening virtually as well.
The nuts and bolts, I'll talk a little bit about telehealth as it applies in traditional clinic care delivery. The nuts and bolts of telehealth for us initially were principally telephonic only. We did not have embedded tools, video tools into our EHR at the time of the start of the pandemic. We worked quite hard to get reliable tools, and we actually went through, I think we burned through 3 different systems, like burned and failed 3 different systems, and we're now in a very happy space with that. So we give customer owners choice. Often we're just like everything else, we're meeting them where they are, and we give them choice in terms of what they want. If their interest is just a conversation with the case manager and maybe some labs and immunization in our tent outside the building, which is our support clinic, great, let's do that. If the interest is more in a conversation with the provider by telephone, great. If you want to have a more involved video visit, awesome. If it's an in-person visit, good. If you're more, if you have, well, with our respiratory clinic, if there was a significant respiratory compromise that needed an in-person visit, that was the place for it. We've now popped down that respiratory clinic, and we're doing a lot of in-person care, but we're using a lot of virtual visits now to determine whether or not somebody has respiratory compromise, whether or not we should or could get COVID PCR testing through drive-through prior to presentation to clinic, those sorts of things. So getting creative in the clinic a little bit.
Wonderful. Thank you so much. We had a couple of questions about this, so I want to make sure I speak to this. But people were asking about burnout. How are we addressing that, not only at an organizational level, but also for individuals, and even for our panelists? How are you addressing burnout for yourself?
Well, Alaskans are famous for enjoying Netflix and alcohol, but I won't make a joke about that. I just did. A lot of us get outdoors. A lot of us are outdoors people. A lot of us care about family, of course, as everyone in the world does. And that has been a really reliable thing for most of us. Connection in teams around family. We have, Mike mentioned earlier, our tradition of check-in. And we actually really value that. If a team member wants to check in and just say hi and ask about your kids, or if you do the same for them, it's very valuable not only for team strength, but also for burnout prevention and for connection.
And I'll just add that we have a lot of support here at SCF. We're very, sometimes I say we're spoiled, but maybe we're lucky. We have a lot of support internally for employees. If you're feeling burned out at all, we have people who are dedicated to working with employees and can join team meetings. We're encouraged to meet with our teams daily. So for instance, in my department, we have a Zoom meeting every morning. And just last week, I asked someone from the behavioral health department to join our team meeting. And we just kind of talked through, our whole hour was spent talking through how are we doing? How are we coping with all of this and what's going on for us? And it was valuable. I think sometimes when people first come to work at SCF, talking about your personal stuff like that can be, it's interesting. It can be new and a little bit scary at first, but we're very used to it here. And it's helpful to help us get through the day, and especially in times like this when it's stressful.
Yeah, I was going to say that I don't know that much was new because so much was in place before. It was things were just maybe increased, that ramped up a little bit, and again, it's worth saying that we've been very fortunate not to have a big overwhelming surge of COVID-19 activity in Alaska. And that's the hope going forward for the next year or two, that it's contained. So we haven't been pushed like some of the places in the world and in the United States have been pushed right now. But like Michelle and Dan were both saying, there are these resources that I've been aware of, for the last 3 years, which seem pretty comprehensive. And so I think just as things ramped up and people were getting more anxiety and busier, it's just a matter of taking what's already in existence and seeing if there's a need to push them out a little bit more broadly. So.
That's a good point that Mike makes, that we do need to be conscious of our privileges. We haven't at this time we haven't been confronted with some of the very, very difficult challenges that other cities have seen. One point, just last point on burnout prevention and wellness, our behavioral health consultants are hired, trained, and wired basically to be there. It's not really their side job, but part of their job is to be mindful of what's happening in the space around them with the staff, their colleagues. And they are very, very good about going into a talking room with a provider or a CMA or a nurse who might be having difficulty. Our managers do the same thing. They're built, wired, trained to help. And so if anyone is suffering there's open hearts and open ears for them right there, like and lots of help, lots of employee assistance. Thank
you. As a former BHC, I concur with that. That is something that is very much a part of the job. Some other questions here. One of them is, what does the response look like in rural areas? We spoke about that a bit, but now that we're several months into this, what does the response look like? What are some of the things that are continuing to evolve in addressing this with our rural communities?
Well, I can take the start of that. So rural in Alaska is actually remote. There's so many villages that you can only fly to or boat to or snow machine to. The privilege there, or the luck there, was that they're just now starting to get COVID cases. So they've had time to prepare, time to adjust. There are some of the more remote places on Earth, as remote as some of the remotest places in Antarctica or anywhere, really. I said Antarctica, Africa. Maybe not nearly as remote as the most remote parts of Antarctica, but remote. And so COVID hasn't really reached them yet, but they've had lots of planning time and lots of worry time. So we've been working really hard on supply chain, on staffing, on logistics, airplane logistics and flight logistics and COVID PCR testing prior to travel, on emergency medical equipment, things like inline HEPA filters and ready CPAP masks and all sorts of protocols that I would have not thought we would have needed to develop. But Alaska in particular is actually experienced in this type of preparedness because we've done quite a lot of work around H1N1 pandemic planning in rural and remote sites. So there was a lot of forward position PPE. There's containers full of ventilators in all the hubs in all the main hospitals around the state that were already there when this all started. And then, so most of the pandemic planning around H1N1 was essentially dusted off and COVID was pasted on in its place. And maybe Mike can talk a little about that too, or Michelle, if you want to.
Yeah, I was just going to add in too that a lot of these remote places also, they were anticipating the introduction of cases because there are also places where there are influx of people to do fishing and crabbing and everything each summer. So there was a lot of infrastructure being built up around that, a lot of testing capacity that was being put in place at some of these hubs where workers from not just around the U.S. but from around the world come every year to go and work. So.
And I'll just add that, we rely on the leadership of the tribal councils in each of the villages. They are the leadership that we're working with. And so each of the villages have their own rules about what's happening in their village, and we're working with those rules. And we want to honor and respect those. And so some of the things that we have done where we have providers is we may leave a provider out in a village longer than we normally would. We may, if it takes 2 flights to get to a village normally, we may do that differently and only charter 1 flight to have a direct flight straight to that village so there's fewer stops. We're doing things like that so that we are respecting the rules of the individual villages.
That's a great point that Michelle makes. And our continuity in relationship, our tradition of trust, and our tradition of co-creation is with village and tribal councils. We've got a long history that goes back over 20 years of doing the same. And we fell back on that, relied on it, and we continue to rely on it going forward.
This is a question more about kind of our process here at SCF. How did we help support staff with really being, especially early on when we were anticipating, worst case scenario, how did we support staff in learning successful like donning and doffing technique and successful virus reduction protocols? What were some of the tools that we used in order to to build our staff confidence and skills in those things?
So I can start there. In the beginning, we put together some videos on how to appropriately don and doff equipment. We have flyers on what PPE is appropriate for each setting. We worked comprehensively through quality and risk and through clinical folks together. We did that together. And then through the Learning Development Center also to put together the videos to appropriately show how to, we did a lot of virtual training, right? So we were moving to a virtual platform simultaneously needing to do trainings with people. And so we did a lot of those trainings virtually. So people in our development center were showing actually how to don and doff appropriately. We also implemented a lodging process that I mentioned earlier, where employees could stay at lodging provided for them if they didn't feel like going home, if they needed to stay somewhere while they were working in higher risk areas. We also implemented a process by which employees could wear scrubs. So we had contracts for scrubs. We don't typically wear scrubs in our settings. We wear street clothes. And so we implemented that process right away. We also tried to support employees in a variety of other ways, just on the job, just right then teaching them. I think there were a lot of things happening in medical services with showing how to appropriately. We did a lot of fit testing. There was a lot of fit testing, still a lot of fit testing going on, and showing how to appropriately use PAPRs, those sorts of things.
Before I talk a little about donning and doffing, just a shout out to the employee health if-then protocols, because the strength of our employee health protocols was a win, and I think the staff could sort of exhale because they knew that we had their best interests at heart. And then to discuss a bit of a failure that we had, it wasn't a small failure actually. We had an initial infectious disease response planning structure that was originally spooled up around Ebola, and it was not needed essentially because we never had an Ebola case. We had some use of it around our mumps outbreak and measles, and we thought it would be effective for COVID. So we had a training of trainers approach, and we had a bunch of champions, and we had essentially small respiratory clinics established in front halls in each of the clinics. And then when we operationalized that, it was not, there were too many small fires at the same time. So, and the response, also we were worried about a surge and we wanted to have surge capacity. So that was actually one of the reasons that we moved towards the establishment of the respiratory clinic.
And then once that was popped up, once the respiratory clinic was popped up, then we not only had the people that had volunteered initially to work there being trained up quickly and becoming very comfortable with PPE processes, donning and doffing, but then we invited and really had managers encourage staff from all over the clinics to come down and even spend a half day there so that once or twice they can just demystify the process of seeing a live customer with COVID symptoms and going through the whole procedure from start to finish. And that, I think, helped a lot too.
Wonderful, thank you. One more quick question. We're now at a time when we're slowly working back towards kind of reopening and getting back to not necessarily business as usual, but something that looks more like business as usual. What are the things that, what kind of planning is in place and what kind of planning is taking place in order to support that?
Well, we established a SCF reopening plan early on, and that went along with our pandemic addendum response. So we have 3 phases of our reopening plan, and we're currently in phase 1 of our reopening plan. Well, level 1 of our reopening plan. And that kind of outlines all the services that will be open and what we'll be doing on site and what we won't be doing on site. We're also looking at what we did during the height of this for us when we really reduced services based on local mandates, what we did then, what we want to keep moving forward to see what was working then and what we could maybe maintain afterwards. So we're doing some of that. We're continuing to do some of the stuff that we were doing in medical services. We're continuing to do as we move forward. We're still doing door screening, lots of pre-procedure COVID testing, lots of stuff that people are doing around the world, I believe, with some of that stuff. But I think that some of the unique things that we're doing are a lot of the telehealth work that is happening, I think is fairly unique, that's going to continue. Dan or Mike?
Yes, I think if we were to carry anything forward from this, it would be the strength of, well, sort of leaping forward to the future with telehealth. And we've long felt at SCF that virtual care is the answer to an outcomes-based system that is customer-focused. And we've stepped away from RVUs. We've stepped away from reimbursement very intentionally in order to deliver an outcomes-based system that works well for the customer and family. I think the rest of the world will probably understand that as they move more towards virtual care. And I'm hopeful that our reimbursement schedules will support that in our nation, at least.
Wonderful. Well, I'd like to thank our panelists for leading today's fireside chat. I'd like to thank our participants for joining and asking lots of really great questions. It's really wonderful to hear the really thoughtful questions that we're getting from everyone. If you're interested in other upcoming training and learning opportunities through Southcentral Foundation, please visit scfnuka.com, and you'll find out about all of our upcoming learning and training opportunities, including our virtual Nuka week, which is taking place July 27th through the 31st. We invite you to come join us for that. Please let us know if you have any lingering questions and give us your feedback in the survey that we'll be sending you shortly. We thank you again so much for your time today. Stay well. Take care.